webinar series have been divided into several sections. So currently, the next three, or the last one and the next two, I think, will be presented by the standards of care, followed by database, and then of course skills. So the idea is to help to focus for a period of time on specific topics to get the thoughts going and get discussion going. So for those people who may not necessarily know, the consortium consists of all of these about 7 countries. So we have the Data Coordinating Center in the south in Cape Town, and then the Clinical Coordinating Center in Tanzania in Dar es Salaam. So the key deliverables for the consortium is to develop this registry of patients, sickle cell patients, to assist with the research, as well as establishing standards of care guidelines to improve the quality of life of patients, of people living with sickle cell disease, and also to conduct support research based on this registry. I'm going to be very quick. We're running out of time, I suppose. So there's several working groups. I've mentioned some of them: the LC working group, the standards of care, database, etc. So all of these working groups attempt to work together to come up with workable solutions to deal with the scourge of sickle cell in Africa, not in Africa only, but in South America and India, where sickle cell is pretty prevalent. So the picture you see is there of Prof Frimpong from Ghana, who basically was a pioneer when it came to establishing standards of care for patients with sickle cell disease. Pioneer in establishing these guidelines that have been adopted, I think, fairly widely to improve the quality of life of people suffering from sickle cell, as well as just caring for them. So for this, we've got the moderators for. I think I'm going to skip this. So currently, we're going to this session will talk about hydroxyurea usage, and you'll hear from the speakers about the experiences and give guidelines and open a discussion where that is concerned. Before we go on, just a few housekeeping rules. So we would like the presenters to start their cameras if at all possible, and if they can keep it on for the duration of their presentation. They can turn it off once they either show their faces and introduce themselves, or once their session is complete. You can type all of your questions at any time in the chat box. And if you do want to ask a question verbally, we will unmute you or ask you to unmute you. At the end of this workshop, there will be a Q&A session where you can freely ask your questions. You can either hold your questions until then, or as I said, you can add it in the chat box. As Emmanuel has pointed out, the session is being recorded. So your presence while this is being recorded will serve as a tacit permission that you can be recorded, and this can be shared on the SickleInAfrica YouTube site. So you're welcome to tweet the speakers. So while they're talking, you're most welcome to tweet your opinions and comments using the hashtag SickleInAfrica Twitter handle. Except if there are any speakers who will be presenting unpublished work. I think then I think the speakers will make it clear, and then it's expected that you do not then disseminate that. I think that is it from me, Emmanuel. So thank you very much.
Thank you very much, Mario. If you can unshare, please, and then I will ask the first presenter to share slides. I will invite presenters in the alphabetical order of their countries of origin. So we'll start with Catherine Segbefia from Ghana. Catherine is senior lecturer at University of Ghana Medical School, and she's consultant pediatric hematologist at Korle Teaching Hospital in Accra, Ghana, and she's part of Sparkle Ghana. Catherine, we are honored to have you. The floor is yours. You will have 10 minutes of presenting, and for all the audience, we will keep your questions. We will listen to all the 5 presentations, and then we'll take questions at the end. So, Dr. Catherine, the floor is yours.
Thank you so much for the introduction, and good afternoon to everyone. It's a pleasure to be asked to speak about the local experience with hydroxyurea. If you don't mind, I think I'll turn my camera off just because the internet tends to be a little bit unstable. So this will be the outline of my presentation. And as we all know, there's been a radical shift in how we approach people who have sickle cell disease. When I was training, the focus was really on relieving acute symptoms. But now we know that there's benefit to actually preventing those symptoms and preventing complications from occurring in the first place. And up until 2017, hydroxyurea was the only drug that was specifically approved for use as a disease-modifying agent in sickle cell disease. And there are many things that make hydroxyurea attractive. It's an oral medication that's given once a day. It can be started fairly early in life, and it has broad ameliorating effects, either directly or indirectly, across different domains of sickle cell disease. And very importantly, we know that the efficacy and safety have been demonstrated in sub-Saharan Africa. So Ghana, as you may know, is a small country on the West Coast. We have just under 31 million people, and 2% of the population have sickle cell disease. And as with most low and low middle income countries, there isn't enough money and there aren't enough doctors, and too many children die. So we are heavily reliant on our public health system. And right at the bottom of the pyramid are the community health services and health centers that do not necessarily have physicians and may not even be able to offer inpatient care and very limited outpatient care. And at the apex of the pyramid are the teaching hospitals, which often have highly specialized staff. Since 2003, there's been a government-funded health insurance scheme, which does cover sickle cell disease, but there's still quite a bit of out-of-pocket payment despite the health insurance. So where I work is Korle Teaching Hospital. It's the largest hospital in Ghana. It's located in the capital city of Accra. And from a sickle cell disease perspective, there are 2 points where care can be accessed. So the Department of Child Health, which has the pediatric sickle cell clinic. We see children up to the age of about 18 years. 1 in 4 of those children have hemoglobin SC disease. And the rest, most of them have hemoglobin SS disease. We run a clinic. We have a big clinic once a week. And I very clearly remember the first patient that I started on hydroxyurea in 2011, a young boy who had had a stroke. And as was the case then, we essentially reserved hydroxyurea mainly for those who had had severe complications. So either for primary or secondary stroke prevention, those who had had multiple pain episodes, acute chest syndrome, and so on. And then we also have the Ghana Institute of Clinical Genetics, which sees people with sickle cell disease from the age of 13 years. So there's quite an overlap with the pediatric clinic. I think it's currently the largest sickle cell clinic in Africa. And they have clinics every day and started the hydroxyurea clinic a little later than we did in 2016. So we were sort of, muddling along with hydroxyurea, reserving it only for those who had severe complications, as I mentioned. And then a few years ago, we did a retrospective review of the morbidity of the children that we were seeing with sickle cell disease. And it really struck me at the time when we realized that more than 75% of those who came into the emergency room, majority of who had hemoglobin SS disease, were actually not on hydroxyurea therapy. And this was around the time where there was evidence showing and evidence recommending that irrespective of severity, irrespective of complications, that people who had sickle cell anemia really should be offered hydroxyurea early. And so fast forward to 2022, and we currently have over 1,200 children who are now on hydroxyurea. We are running our clinics twice a week because the once a week clinic was really not enough. It was really very crowded and too heavy. And so we moved particularly a lot of the patients on hydroxyurea to another clinic day. And currently we have no severity criteria for offering HU to those who have sickle cell anemia. I must say though that unfortunately, the majority of our patients are still being diagnosed opportunistically, meaning that they're coming in with complications. And then we find out they have sickle cell disease, and then we offer hydroxyurea. But we do have a population of children who've been diagnosed through newborn screening. And our guidelines are that we offer hydroxyurea. We start to talk about it from the age of 9 months. In our adult population, the number of people with on hydroxyurea has also increased to about 500, and their HU clinic is held twice a week. So what are some features of our HU program? The first is that it is very heavily nurse-driven. We have an amazing hematology nurse specialist who leads the counseling sessions for hydroxyurea. And one of the reasons for that is that being a teaching hospital, we have a very high turnover of junior doctors. And so our nurses are the ones who are there most of the time. They're the ones who've been there the longest. And they are the ones who have really gained capacity in terms of hydroxyurea use and management and counseling. And often we will hold these counseling sessions on off-clinic days because the clinics are very busy. So we will schedule the family to come in, and we often will address the burning issues head on. So yes, this is a medicine that has been used for many, many years to treat cancers, because that's often the fear that a lot of people have. So we mention cancer very early on in the conversation and address any issues that families may have. We also tend to bring the families and the children back in 2 weeks after we've commenced hydroxyurea. And that is really a reinforcement visit. It's really to find out about adherence and address any practical issues that they may be facing. And if at the first visit we didn't have all of the primary caregivers present, let's say that we only had one parent, then at the 2-week visit, we make sure that we have the second parent available as well for counseling. Up until recently, hydroxyurea was only available as a 500 milligram capsule. And so for the children, that was a problem in terms of dosing. And so our pharmacists are able to compound it to make a preparation that children can easily take. But in the last month or so, we've had a dispersible form of hydroxyurea available. And then even before COVID, and especially since COVID, we rely a lot on remote monitoring of laboratory results. So we do obtain consent from families so that their results can be sent either by email or WhatsApp. And the nurses, again, are trained to review these results so that if there are any issues, then they will communicate with the families. And often we will give these lab request forms ahead of time because we see the patients every 3 to 6 months. But early on in treatment, we're doing the lab tests monthly. Now, unfortunately, really the story in Korle is not the same across the country. And there are many regions in Ghana that do not even have sickle cell treatment centers and do not have people who are trained in hydroxyurea use. And so in a bid to reduce that disparity, in 2019, the Sickle Cell Foundation of Ghana, Novartis, and the Ghana Health Service and Ministry of Health signed a memorandum of understanding. It was really a broad MOU way beyond hydroxyurea, but hydroxyurea was one of the main pillars of that MOU. And in preparation for that MOU in 2018, the FDA of Ghana granted marketing authorization to Novartis for hydroxyurea. And the Ahojo program, which I'll talk about very briefly in the next slide, was launched in 2019. And in 2022, hydroxyurea is currently available on our National Health Medicines list. And in 2022, just a few months ago, as I said, we now have the pediatric friendly formulation. So the Ahujo program, which really was the brainchild of Professor Hene Frimpong, was really to see whether we could implement HU on a large scale within the public health service. And Ahujo in the Akan language of Ghana means comfort or relief. So this was really a relief program. And it was hinged on a treatment protocol, which is very similar to what is used elsewhere, but was adapted for Ghana. We established treatment teams for hydroxyurea in hospitals that already had sickle cell clinics. In the first phase, 11 centers, and in the second phase, 9 additional centers. There's also the use of a mobile application to register patients, document toxicity, and so on. And Novartis provided free hydroxyurea for the program, which is distributed by the Ministry of Health and overseen by the Sickle Cell Foundation of Ghana. The leads of the hospitals involved in hydroxyurea care form steering committee, and their meetings that are held regularly. And very importantly, there was a lot of advocacy to get hydroxyurea on the national health list. So this is just a snapshot of the treatment protocol. Again, there is no severity criteria in terms of clinical symptoms. Once you have sickle cell SS or SB not, you're eligible. We start at the age of 12 months, but we have started earlier in several children, depending, so from 9 months. Those are the starting doses of hydroxyurea and the baseline tests that are done. It is a dose escalation protocol, which is done every 8 weeks. And we monitor labs initially every 4 weeks, and once they're on a stable dose, every 12 weeks. So as at the beginning of this year, this is an abstract that we put together. There were almost 4,000 people, adults and children, who were on hydroxyurea across the country. So what are some of the challenges? Well, hydroxyurea is on the health insurance scheme, but the monitoring labs like the renal and liver function tests, hemoglobin F levels, and so on are still out of pocket payments. The film-coated tablets, the dispersible tablets, are currently not on the insurance scheme. So that is also still an out-of-pocket payment. So it's just the 500 milligram capsule that's available. There's still a lot of misconceptions about HU, including amongst healthcare workers. And because it is a specialist medication, you have to be at a certain level to be able to prescribe it. But we know that those who have sickle cell disease are not only seen in the teaching hospitals and in the regional hospitals where the specialists are. And of course, we recognize that hydroxyurea doesn't always work, and the alternatives aren't really accessible for those who need it. And particularly in our hospital here in Accra, we need to improve the transitioning from pediatric to adult care. And from the beginning of next year, we're actually going to be holding joint clinics with the adult physicians. And so my final slide, just looking beyond sickle cell anemia, we have currently started a phase 2 trial for hemoglobin SC and hydroxyurea in children and adults with sickle cell disease. This was recognized as an area of unmet need. And this is a phase 2 trial for those between 5 and 50 years. It's a double-blind randomized placebo-controlled trial where we are looking at not just the safety of HU, but trying to identify which clinical or laboratory endpoints will be suitable in a definitive phase 3 trial. So we're about halfway through enrollment for this study. And over the next few months and years, you will be seeing the results of that. So I will end by acknowledging this amazing man who really, as was said earlier, has been the pioneer of sickle cell disease, the beacon of sickle cell disease, not just in Ghana, but across Africa. And, it was a terrible, terrible blow to us when we lost him earlier this year. And I'd like to also acknowledge the Sickle Cell Foundation of Ghana for their work. So thank you very much again for the opportunity. And that's the end of my presentation.
So thanks very much, Catherine, for that presentation. So we have the next presenter, Dr. Sekou Kene. Sekou, are you able to share your slides?
Okay.
Please go ahead and share as I'm introducing you. So Dr. Sekou is a sickle cell specialist and a clinical hematologist from Bamako, Mali. He is coordinator of blood transfusion and bleeding activities at the Sickle Cell Disease Control Center, CRLD, in Bamako, Mali. So, Dr. Kene, we are happy to have you. The floor is yours.
Okay. Our experience to use hydroxyurea in Mali. So my presentation will be in this plan, starting by introduction, current practice of CRLD, and I talk about our site description, hydroxyurea formulation, hydroxyurea doses, patient under treatment hydroxyurea, and the monitoring. And what about challenges in using hydroxyurea in our seat, perspectives, and conclusion. The sickle cell disease is the most common genetic hemoglobin disorder in the world. The disease is progressing. The progressing of disease is marked by the occurrence of acute chronic complication. Patient survival is considerably improvement by the new therapies. The drugs is the first disease-modifying therapy in the major forms of sickle cell disease, according to study of Sheres and all on their study effect. Excuse me. And the study of effect of hydroxyurea on the frequency of painful crises in sickle cell anemia, and is weekly used in the developed countries. According one and all study, who talk about a multi-center randomized controlled trial of hydroxyurea. And according to Chilo and all, the hydroxyurea is immediately used in Africa for availability and for the cost. How about our site, Sickle Cell Disease Control Center? It is the public structure specializing in the research and the fighting against sickle cell disease, functional since 2010. We have now 4 departments: administrative department, training and research department, medical department, and communication department. Actually, we have more than 15,000 patients with regular follow-up. How about our, can you hear me?
Yes, we can hear you.
Okay, okay. What about our current practice of CRLD? Hydroxyurea formulation is registering in the list of essential medicines for the management of sickle cell disease. We have only one formulation in Mali, like a capsule hydroxyurea from 500 milligram, and there is another formulation like a tablet, Cyclos, to 100 and 1,000 milligram. Okay. For indications, we have 2 things, and the vaso-occlusive crisis, 3 vaso-occlusive crises per year, and 1 severe acute chest syndrome. And we use hydroxyurea to prevent of damaged organs like kidney disease, heart disease, liver disease, brain and leg ulcers, and priapism, etc., etc. How about doses? The start hydroxyurea dose at 15 to 20 milligram kilo. And we gradually increase to maximum tolerated dose based on the response treatment at 35 milligram kilo. Down here, we have a patient who is under who takes hydroxyurea in 2021. Donc, then we have 457 patients were under hydroxyurea treatment. According to 249 females and 208 males. Donc, started dose, initial dose were 20 milligram kilos. Average started age is treatment 20 or 13. The predominant indication there is repetitive vaso-occlusive crisis. And the phenotype, we would take hydroxyurea where the SS, SC, and others were 7%. About the monitoring of toxicity, it is based to lab results, complete blood cell count. If we have some results less than, like a platelet less than and put in Mali is we have only one presentation in Mali. A formulation 500 milligram. It is a problem. The second.
I think we have lost Kene. Hello, can you hear me, Keita?
Emmanuel, I think Keita dropped.
Okay. All right. So let's see if they can join back. But I think maybe let's just wait for 1 minute. But in the meantime, there were some questions asked to Dr. Catherine. Dr. Catherine, you want to spend maybe a minute to address those as we're waiting for Kene to join?
Thank you very much. I think I've responded to both questions. So the first question was whether we plan to continue with the mobile app as we roll out hydroxyurea nationally. And the answer is yes, that's the current plan. That will be the central method for data collection. There was another question about people with hemoglobin SC. So with SC disease, we do offer hydroxyurea, but on a case-by-case basis. But as I mentioned, we are currently carrying out a phase 2 trial of hydroxyurea in SC disease and what the safety is in SC disease. So we'll have those results in the next few months. And then there's a last question about whether there are any notable side effects in children under 2 years. And we find that the very young children actually tend to tolerate hydroxyurea very, very well. And I probably could count on one hand the number of times that we've had to interrupt HU for toxicity. So they do tolerate it very well. There are no notable side effects. And regarding plans for advanced therapy, exchange transfusion, HSCT, gene therapy in Ghana, I think that we're all looking forward to that. There was, for a very brief period of time, a hospital in Ghana that was offering HSCT, but unfortunately that the plans for that unit didn't quite materialize, I think, the way that it was intended. We do exchange transfusions, but we do manual exchange transfusions. We're not able to do erythrocytophoresis at this time. We are also currently running a phase 3 trial of voxelotor, so another one of the disease-modifying agents. So I think that with time, yes, we're hopeful that we'll be able to offer more advanced therapy for children and others who have sickle cell disease. Thank you.
Thank you very much. I think Dr. Keita is not able to join. If they are, then we'll give them minutes toward the end. We should move to the third presentation by Dr. Hezekia Isah. Dr. Hezekia, you can share your slides. Dr. Hezekia is Senior Lecturer at University of Abuja and Consultant Hematologist at the University of Abuja Teaching Hospital. He is Secretary at Sickle Cell Support Society of Nigeria and Clinical Coordinator for SparkNet and member of SPARCO Standards of Care Working Group. Dr. Hezekia, you're welcome. You have 10 minutes. The floor is yours.
Good afternoon, everyone. I'm glad to share the experience of use of hydroxyurea in Nigeria. So by way of introduction, hydroxyurea is a disease-modifying drug in sickle cell disease, and it does this by reducing fetal hemoglobin production, improving cellular hydration, mild myelosuppression, reducing cellular adhesion, and the production of nitric oxide, which is a natural vasodilator. Several studies have shown that hydroxyurea is effective in reducing morbidity in sickle cell disease, such as acute chest syndrome, vaso-occlusive crisis, stroke, and blood transfusion. So hydroxyurea used as a government policy in Nigeria, the national guidelines for the control and management of sickle cell disease in Nigeria, which was formulated in 2014 and currently undergoing revision, recommends hydroxyurea therapy in sickle cell disease patients. And the indications include greater than 5 crises per year, 3 to 4 crises with neutrophil count of greater than 10 times 10 raised to power 9 per liter, or thrombocytosis of greater than 500,000. Other indications include acute chest syndrome, abnormal TCD of greater than 200 centimeters per second, and stroke. The dose is 15 milligram per kg body weight per day, with dose escalation by 500 milligram per kg per kilogram body weight at 3 to 4 weeks intervals until a satisfactory clinical response is achieved. However, not exceeding 35 milligram per kilogram body weight because of toxicity. Hydroxyurea has been captured in the National Insurance Scheme. Previously, in the last 2 to 3 years, it was not included in the insurance scheme. So even if patients have subscribed to the scheme and they need hydroxyurea, they cannot get it because it was not included. But now it is captured in the National Health Insurance Scheme. So our patients who have subscribed to the scheme access hydroxyurea. However, there is very low coverage of the population in the scheme. So many patients are not even on this scheme because it's mainly restricted to public servants and maybe corporate private organizations. Most patients are not covered. In terms of frequency of utilization of hydroxyurea, the frequency of use of hydroxyurea has been increasing in the last decade. In 2014, less than 1% of sickle cell patients were on hydroxyurea. By 2018, we had up to 9.4% of patients on the hydroxyurea. And in 2022, according to a survey that was conducted nationwide, we have 15.6% of patients that are on hydroxyurea. Although in some centers, they give it to more than up to 50% of their patients may be on hydroxyurea. But generally, this is the average across Nigeria. The frequency of prescription by doctors, less than 50% of doctors prescribe hydroxyurea to their sickle cell patient. And these are mostly hematologists and pediatricians working in tertiary hospitals. About 90% of them that prescribe hydroxyurea prescribe it to less than 20% of their patients. Among the nurses, only about 1/3 of nurses counsel and educate patients on hydroxyurea in the previous 6 months, according to a survey that was published in 2020. Then we have facilitators and barriers to hydroxyurea use. We have patients-related factors and healthcare providers-related factors that determine the utilization of hydroxyurea. For patients, facilitators include reduction in of crisis, and the patients that have used it confess that it has no serious side effects. This encourages them and motivate them to continue to use hydroxyurea. And the barriers among patients include the high cost of the hydroxyurea, and many of them are worried about cancer, complications such as cancer, infertility, and then the cost that is also involved in the frequent hospital visits because they are on hydroxyurea and they are being monitored, and also the lab investigation. It adds discourage them from using hydroxyurea. And among doctors, good knowledge of hydroxyurea and the fact that there are a lot of clinical benefits and the cost effectiveness of hydroxyurea in managing sickle cell disease patient is a facilitator. They are facilitators, whereas the barriers include inadequate knowledge and lack of awareness of the existing guidelines. Among the nurses, clinical benefits and the fact that there is no serious side effects associated with hydroxyurea make them to vet them to adhere patients to adhere to the drugs, to the medications. The barriers include workload because the patients nurses to patient ratio is very low, so that is a barrier to telling patients about the use of hydroxyurea. So about concerning the availability of hydroxyurea, there are both imported and locally manufactured hydroxyurea brands the price for the locally manufactured Hydroxyurea, which is manufactured by Bond Chemicals, for 30 capsules, it costs about 4,500 Naira. This is equivalent to about $10 at the official exchange rate. And although it's cheaper if it is procured directly from a company sales representative. The imported brands, they come in packs of 100 capsules per pack, and the cost is about 17,600 for 500 milligrams, and that is about $40. So it is available in most teaching hospitals, but there are usually frequent out of stocks. Then there is also available in big pharmaceutical stores, which are located mostly in the city. So outcome of Hydroxyurea therapy, I've full studies from the various centers, and some of these studies are actually multi-centered about their experience in terms of outcome. And these studies that I have referenced here have shown that Hydroxyurea is effective in terms of reducing the frequency of vaso-occlusive crisis, the requirement for blood transfusion, hospitalization, and so on. And that Hydroxyurea is also safe. They've not recorded any significant or severe side effects. So in conclusion, Hydroxyurea is part of the standard care for sickle cell disease in Nigeria. Now, it is a part of our essential drug list and is captured in the National Health Insurance Scheme. It is an effective and safe drug. The frequency of use is still low, although it is increasing because of increased awareness. Barriers to use include inadequate knowledge and awareness, high cost of Hydroxyurea and monitoring of Hydroxyurea therapy, and the problem of non-availability. There is need for a training of healthcare providers, more dissemination of management guidelines, patient education, and increased insurance coverage for patients with sickle cell. Okay, thank you. These are the references I use. We are preparing for this presentation. Thank you.
Thank you very much, Dr. Hezekia, for that excellent presentation and for keeping it on time. Because of time, we'll move straight to the fourth presenter, Dr. Emmanuela Ambrose. Dr. Hezekia, if you can unshare your slides so that Emmanuela can share. Dr. Emmanuela is a pediatrician and lecturer at Department of Pediatrics and Child Health at Catholic University of Health and Allied Sciences in Bugando Medical Center. She has interest in sickle cell disease, stroke prevention particularly, and she's currently the country lead for Tanzania on Hydroxyurea study, and she's a PhD fellow. Emmanuela, if you can share your slides. Yes, please. The floor is yours. You have 10 minutes.
Thank you. Good afternoon, everyone again. So I will take you through Hydroxyurea use in Tanzania, experience and challenges. Do you hear me?
Yes, we hear you very well.
Thank you. I'm sorry. So I love this slide that we know that there are a lot of complications associated with sickle cell disease, being anemia, hand and foot syndrome, acute chest syndrome, avascular necrosis, stroke, and so on. And we understand that we don't have enough blood supply in order to treat these conditions as one of the disease-modifying therapy. So hydroxyurea comes in with a lot of good effects, and starting with the hemoglobin F induction. Also in the this paper was just submitted, we find that hydroxyurea is really great in increment of hemoglobin MCV and decrement of ANC and retics count, but it does more than this in a longer follow-up of the patient. So I'm speaking from Bugando Medical Center as a pediatrician in sickle cell unit and also a lecturer in MUHAS, and that is our hospital that you see on the right side. And all this is located in northwestern Tanzania, but representing SPACO in Tanzania. So there are a lot of estimations of sickle cell disease in Tanzania, despite that majority has been reported to come from the northern part of Africa. We understand the prior study estimations with 11,000 of people who are born annually with sickle cell disease, but more have been reported in northwestern Tanzania. Oh, sorry. Okay. So in Tanzania, despite of very high numbers of sickle cell disease, there is a use of hydroxyurea, but due to these high numbers, still there is low access to hydroxyurea, which is the most common disease modifying treatment and is very essential and life-saving. So we know that it prevents acute complications and mostly debilitating stroke, and also it preserves organ functions. And if the healthcare providers understand well on hydroxyurea, it's very easy to educate the patient so that the patient can get adhered to the medication and get preserve the organs and decrease the other complications associated. There is a use of hydroxyurea, but I can say it's minimal used because still obtaining hydroxyurea to the district and other areas still is low. The challenges are like a lack of drug availability at a specific area, because mostly you can find at big cities and regions. Affordability is hard sometimes to some people because mostly the NHA health is presented to few. Despite that, we are happy for our government that now you can get hydroxyurea even in a very cheap national insurance fund that has been given to our pediatric population. And also there's a lack of prescriber familiarity to the dose monitoring and adjustment, but due to different trainings that are ongoing through SPACO and through other institutions, we hope this will be improved. Also, the cost of the drug itself and associated laboratory monitoring is a bit prohibitive to some families who don't have insurance. So in Tanzania, we are happy to say that we have increased utilization of hydroxyurea from 1% to 20%, and this is from our SPACO database, which is very helpful to know these numbers. And also we are happy that it has been included to National Insurance Fund, but not everyone is able to access the National Insurance Fund. We try to advise our pediatric population all to register to the fund so that they can obtain hydroxyurea for free. Also, increased numbers of hospitals providing hydroxyurea is not as before. After education is when more number of hospitals has been providing hydroxyurea, but not all to cover the whole country. In some areas like in Dar es Salaam, hydroxyurea has been lowered in price, but other areas it's still like probably can reach $1. It's about $0.8. And we are so happy that our national guideline has included hydroxyurea, and our sickle cell guideline have included the hydroxyurea, and it explains very well on hydroxyurea therapy, on management of sickle cell disease, when to give, when to stop, and how to utilize our 500 milligram tabs in order to fit every weight of the baby, of the child that we are having. So the way that in Tanzania, we are happy that different education has been provided to our healthcare provider in different areas. So our healthcare provider can use even this Sparkle provided passport and fill the hydroxyurea, and also counsel patients on hydroxyurea use. And also we are happy that patients have been improving on hydroxyurea and they're happy. And you can see the picture on the right. This is one of our patients with sickle cell disease have worn this quote saying that I'm a future hematologist. So after hydroxyurea, I find my life is much better and I can run and exercise. And another thing, we are happy with our community sickle cell groups. In Lake Zone, we can say Tasiwa, but in Tanzania, we have different sickle cell community working groups that are happy and eagerly educating people on that hydroxyurea is the best drug. So in conclusion, we can say hydroxyurea significantly improving clinical outcome and the hematological parameter in children with sickle cell disease, but we need urgent efforts to disseminate treatment guideline in all centers at our part, to do more training, despite that there are training ongoing, but to disseminate this training even to other areas at interior where there are sickle cell patients. And also hydroxyurea have to be accessible everywhere and affordable to all centers. So before the new expensive treatments, including curative treatment options, within that hydroxyurea must be first become widely available, and also its price have to be lowered to the affordable range everywhere in Tanzania and probably outside Tanzania. So acknowledgement to Sparkle Tanzania, my institution, and sickle cell community groups. Thank you so much.
Thanks very much, Dr. Emmanuela, for spending 7 minutes. If you can please unshare so that we can welcome Dr. Pamela Chidawanyika to share slides. I'll introduce Pamela. She's a lecturer in internal medicine at the University of Zimbabwe, and she's part of the sickle hemoglobinopathy research in Zimbabwe and Zambia, or SHAZ. So, Dr. Pamela, we are happy to have you. The floor is yours. You have 10 minutes.
Good afternoon. It's an honor. I am presenting on behalf of Zambia and Zimbabwe. So I tried to condense into a short presentation of both countries. Okay. So the content of my presentation is going to be on the successes, experiences, and challenges faced by either the two countries, Zimbabwe and Zambia, and the lessons learned from both regions. So I'm first going to talk about the successes in Zimbabwe. Hydroxyurea has fortunately become an essential drug in Zimbabwe and has become, therefore, the standard of care in both adults and children with sickle cell disease. It's also been supplied for free by Kene in children under 18 years at Gorejena-Chidawanyika group of hospitals, which is in Harare, in our capital city. Kene is an association that offers a lot of clinical support, psychosocial support for children with cancer. And they also go beyond and sometimes do a lot of funding to raise money to support children with cancers. We also have had corporate support with private-public partnerships to support hydroxyurea prescription. Specifically the, sorry, apologies. at the Bindura Sickle Cell Disease Clinic, which is now being run independently, and the inception was on the 17th of June of this year. Our ministry has also adopted the PEN Plus package for non-communicable diseases related to sickle cell disease. And we have also adapted the same package materials to our context. Another success is that monitoring of hydroxyurea related side effects occurs pretty much at all level hospitals in Zimbabwe, and we're able to do full blood count, a liver function test, and urea and electrolytes and creatine with ease. Another thing is a lot of talks have been held with Novartis in 2020 to have some Novartis support the supply of hydroxyurea. But we need to go back to the table with our Ministry of Health to improve access of hydroxyurea to Zimbabweans. So our experiences and mostly challenges, despite having hydroxyurea being labeled as an essential drug, it's assigned in a category where there are no resources. So the council that's responsible for development of medication can sideline it, unlike the same way that can sideline it, unlike antibiotics and antiretrovirals, which holds a certain precedence in our country. The current stocks of hydroxyurea, which have said earlier have been made available through KidsCan, have unfortunately run out. And hydroxyurea is not readily available at provincial, district, or rural hospitals, even though it's an essential drug. So I must say it's, at the moment, it's readily available in the capital city, which is Harare, and the perinatal hospital, which is a central hospital, but not readily available in the peripheries. The other challenge we have is that we have a 500 milligram capsule formulation, which makes prescriptions for pediatric patients very challenging. And also in terms of the monitoring, only a limited number of provincial hospitals and the 4 central hospitals offer a clotting profile. I'm going to move on to successes in Zambia. The national guidelines were launched in 2020 in Zambia, and they've streamlined the use of hydroxyurea by narrowing the indications and mainly to the sickle cell disease related complications, as mentioned. And once it's an essential drug, it makes it easier to lobby for its use. The Ministry of Health is engaging companies that can assist with this provision. There's a memorandum of understanding between Ministry of Health and Novartis at present. And there have been a lot of health units which have been opened up by the Ministry of Health in various aspects of the country, and I understand mainly in the northern parts of Zambia, that can cater for sickle cell disease patients. And at present, they're expecting a large consignment to be brought into the country. Amongst the successes, I think Zambia has come up with the parent-patient support groups, which have advocated immensely for children with sickle cell disease. They've advocated for opening of hematology units in health institutions. They lobby for outpatient clinics to be run at those hematology units, and they also lobby for hydroxyurea to be made available in these centers. They even go as far as finishing the outpatients department and making it a more presentable and workable environment for both the health service providers and the patients. Currently, they're working with a United States-based company that has FDA-approved point-of-care tests, which are in the process of being validated. There's also been donations of hydroxyurea from Germany through Novartis. And the other achievement is an at least this year, they noted that they've adopted approximately 1,000 patients with a goal to provide hydroxyurea to all these patients and to provide it consistently as well. And they have also come up with mechanisms to identify the vulnerable patient. I thought this was quite impressive and innovative. The challenges faced in Zambia are that all things that are, things that are drugs that are provided for by the government, and they can, when the drug runs out, procurement of these drugs can only be done in private, and sometimes this is beyond the reach of most of their patients. And then another slight challenge, but I think it's that can easily be overcome, is that the donations that have come through Germany, through Novartis, they're in the process of going through the regulator because the leaflet is not in English. But I think this is just a minor hurdle, and translations are in process. So finally, the lessons learned, I think is both countries, Zambia and Zimbabwe, have learned the importance of private-public partnerships. As much as we would like to rely on our ministries, they also face their challenges in provision of hydroxyurea to every patient who requires it. And I thought, I'm from Zimbabwe, but I thought we could take a leaf from Zambia, that after the parent patient support groups, I thought were very innovative, and generally once you involve patients in their care, it also assists their ultimate well-being. I would like to acknowledge Dr. Patience Sekou now, who is the PI of Zimbabwe SHAZ, and also Dr. Catherine Chunda Lioka, who couldn't be available today, but I'm presenting on her behalf the Zambian information. And thank you. Should be my last slide.
Thanks very much, Dr. Pamela.
Sorry, I realized I switched to my video.
Great presentation. I would also like to thank all presenters. I think we've had a very good snapshot of the status of hydroxyurea in our countries. So I want to thank all presenters for that. Thank you, all participants, for staying a little bit over time, but I think I'm hoping that you can be with us for a few more minutes so that we can ask important questions. And Haida will be posting a link on the chat for you to provide post-webinar feedback. These are very important for improvement of future sessions. So please visit the link. I will start with, there's a question that was posted, and I think this cut across many countries. I think it's only Ghana that doesn't have indication for hydroxyurea utilization. Everybody else has indications. So how are we moving forward? Do we still need to keep these indications? And I think David Jailos asked the opposite question, which is, are there contraindications to using hydroxyurea? So I'm not sure if Kene, are you on? If you can start to respond to that question, the issue of indications and contraindications for hydroxyurea utilization. If Kene is not on, maybe we can go to Emmanuela. Do you want to speak about this issue of indication, contraindication?
Hello, Emmanuela.
Hello, this is Kene?
Yes, I'm here.
Yes, please. Can you answer the question?
Questions for what?
Regarding indication and contraindications to using hydroxyurea.
Hydroxyurea is indicated in CVO
I think we're having difficulties connecting to you, Ken.
Yes, indications, the current practice of serial D. The indications are 3 CVO, vasocrisis per year, and 1 severe acute chest syndrome. And we use hydroxyurea to prevent organ damage, like kidney disease, heart, liver, brain, leg ulcers, and priapism.
Thanks very much. Dr. Emmanuela, do you want to add in on that?
Yes. For
Yes,
hydroxyurea, we make sure now at least every child when reach 9 months of getting hydroxyurea. So one of the indication is to give hydroxyurea since infants at 9 months. And we have seen that if hydroxyurea is being given early before complication to start up, then the effect of hydroxyurea is really good. And for the other indications, for those who have late, as with the other presenter, the acute chest, the painful crises, prevention of secondary stroke, even the prevention of primary stroke, if you can afford to do the TCD and determine that you have a risk. So all the complications of sickle cell disease may be one indication for hydroxyurea, but we recommend to initiate hydroxyurea before all complications, that the hydroxyurea will have the best effect. And the contraindication for hydroxyurea, the serious one is hypersensitivity, but really the contraindications are temporary, because when you give endophthalmitis, there is thrombocytopenia. After you withhold the drug and return the drug in 1 week, then the drug can work very nicely in that. So there is a temporary contraindication when you have lowered cell lines in your full body picture or peripheral blood smear. That's all I can say.
Thank you so much. So I think it appears to me that those are, safety issues once it's been introduced. So in other words, every patient should have a chance of trying hydroxyurea, and then if they cannot tolerate it, then you can withdraw it. But other than to say certain patients should not be tried on hydroxyurea, and I'm not sure if any issue. I hope that's clear. But the issue is, I think we should advocate for the drug to be widely available to as many patients as possible.
Yes.
Yes, I can open the floor now for questions. Anyone with a question, feel free to unmute and ask. There was one question in the chat. Is there any possibility of using micronutrients in some of food substances for management of vaso-occlusive crisis? I think we need to think outside the box to adapt cheaper, safe, and acceptable interventions. I think this is to any presenter. But someone else wants to ask another question? Okay, you can also raise your hand so that we can unmute you. So you have that option also. There was a question on the chat. I think there are 2 participants that have raised hands, Takudzwa and Ese, and Okwi, 3 of them. So Okwi, I think you're unmute. Okwi's hands down. Takudzwa and Ese.
Okay, good afternoon, sir. Good afternoon, everybody. My question is, do we necessarily have to do hemoglobin F before starting hydroxyurea? Sorry, I joined the meeting a little bit late. I didn't get the calculation of the time. I'm speaking from Nigeria. I didn't get the calculation of the time early enough. So I thought it was 3 o'clock, which was that I discovered it's South Africa's time, that was 3 p.m. So I don't know how far the discussion had gone, but my question is, do you necessarily have to do fetal hemoglobin? Because we know that as part of the mechanism of action, there is elevation of, or want to use to achieve a raised level of fetal hemoglobin to reduce sickling. Do we have to do quantification of fetal hemoglobin to know what the certain percentage before we commence on hydroxyurea, or can we just give it to all our sickle cell patients? Start on.
Thank you very much. That's very clear. I'll ask Hezekia to respond to this and also respond to the question of how frequent we have to do laboratory monitoring for toxicity. Hezekia?
Okay. We use hydroxyurea increases fetal hemoglobin, and that is the rationale in which we need to do fetal hemoglobin before starting. The understanding is that if patient already has high fetal hemoglobin, place him on hydroxyurea. But again, if we check the mechanism of action of hydroxyurea, is not only restricted to increase in fetal hemoglobin. There are other, so many other mechanisms. So we don't really have to do hemoglobin F always before we place them. And we know the long-term benefits of hydroxyurea in terms of preventing chronic complications. So I think that more so in our environments, even the facilities to do hemoglobin F, they are hardly available. So the need for doing is not compulsory that we do the hemoglobin F before commencing the therapy.
Okay.
Thanks very much.
Thank
That's
you
very
very
helpful. Akuzo, your hand is up.
Hello, Emmanuel, how are you?
I'm good.
Actually, patients, my link was not working.
Okay.
So it's Patients Corner from Zimbabwe.
Yes,
I just wanted to comment on the use of micronutrients for improving the outcomes of sickle cell disease. I think it has been researched. Quite a number of micronutrients have been described. But it looks like a balanced diet with all the nutrients is important for as a disease modifier. I think even if people look at the literature from West Africa, they've got specific diets that they sort of give people with sickle cell disease that reduce painful crisis, especially. But there are specific micronutrients that have been looked at. Some of the omega-3, some people look at zinc, quite a number, but it looks like you need to have a number of nutrients to address the nutritional goals for sickle cell disease. And the ones who are well-nourished tend to have less severe disease. And other people have used ready-to-use therapeutic foods. I think there's some research from Tanzania to that effect. That's my comment. Thank you.
Thanks very much, Patience. I think there is a need to continue exploring this. Even in Tanzania, I think there are always new alternative therapies that are coming. But obviously, we have to follow the good clinical practice and ensure that we are doing proper clinical trials before we recommend any one of those. So thanks very much. We have Ibrahima.
Hi, Professor.
Yes.
Hi, everyone. Dr. Kene want to know how many forms of hydroxyurea was used on the other side.
Okay.
The form of hydroxyurea. Yeah.
Very important question, because I think in Ghana, Catherine has left, but I think Vivian can respond on behalf. Ghana, they already have a dispersible formulation, but in other places, 500 milligram tablets that are being eluted. Can Vivian speak to this? What kind of formulation do you have in Ghana, and the dispersible formulation, who is supplying it?
Okay, thank you, Emmanuel. So we have the 500 milligram capsules, which was the one that was initially started for everyone. But just like about 2 months ago, that was when the dispersible formulation was given. It is 2 strains. I don't remember it often, but it is dispersible, such that even if you need some, you can just like break it. Although it's dispersible, it's such that you can break the tablets into 2 and then possibly use half. I think it's 200 milligrams. I'm not very sure about the strength, but you can break it, use it. There is a line between it so that it will make it easy for you to break it, so that you can get the correct strength that you need for the patients. So those are the ones. So, but the dispersible ones is a bit more expensive, and mostly it's Novartis which supplies it for us. Thank you.
Okay, thanks very much. So we know now Novartis has that formulation, so maybe it's a matter of engaging. I've seen Novartis is engaging in various countries. Maybe you can take 2 more questions, and then that will be it. Diane?
Yes, hi. I'm Diane Kiadi from Kinshasa in Congo. I have a question about the escalation of the doses of hydroxyurea. I heard in one presentation that increase the dose after 8 weeks. I'd like to know if it could be faster than 8 weeks. Is it because of the toxicity of the hydroxyurea on the blood cells that we need to wait 8 weeks, or does anyone have experience in accelerating the dose to the maximum tolerated dose faster than 8 weeks, for example, 4 weeks or 3 weeks? Thank you.
Thank you very much. Who wants to respond to this? Pamela? No, Pamela is not there. Is it Patience? If not, then any one of the presenters.
Hello, sorry,
yeah.
Emmanuel.
Yes, Pamela.
It's Patience. I'm sorry.
Oh, Patience. Yes, yes.
Yeah, I didn't quite get your comment. I missed part of it.
Yeah, the question is, why wait until 8 weeks before dose escalation? Can we do faster dose escalation?
I think the guidelines of introducing hydroxyurea, sort of, you introduce it at a particular dose by 2 months, you check. You want to give it time for the hemoglobin to respond, and also you are also monitoring the other things like the liver toxicity. The actual, when you give, I think for the hemoglobin, you can check after 1 month when you introduce it. But the liver things you have to check around 2 months, I think. That's when you check it. So you need to give it time to have an effect. If you get through 2-3 months and there's no the hemoglobin has not responded as expected or enough, you then escalate it.
Okay. So maybe that's just unfortunately the biology, you can't go faster. Then the last question will be from Okwi.
Oh yes, thank you, Mr. Chairman. First of all, I would like to thank all the organizers of this conference. And I would also like to thank especially Catherine from Ghana. She talked of Frimpong Ohene. Frimpong Ohene happens to be my good friend. We happen to have met some years back, in one of the conferences here in Uganda. And I only that I lost his contact. I would have loved to find out how he's now doing. Having listened to a number of presenters, actually, I realized that a lot of the presentation was actually focusing on the benefits of the hydroxyurea, other than on the side effects of hydroxyurea. In order for this drug really to be acceptable to the societies or to the communities, I think people need to need to know holistically the side effects of the drug. Now, in fact, even the side effects that are currently being reported could be on just short term, medium term, but not on longer term. I think this needs to be addressed very seriously. I remember very well that some time back, and that was, I like reading about sickle cell disease because my PhD actually was in sickle cell disease, and I happened to have a last born of mine who's a sickler, who's suffering from sickle cell disease. That's why I picked interest in sickle cell studies. I remember reading on the issue of nutrients. That's why I posed that question of nutrients, use of micronutrients from management of vasculation crisis among sicklers. I remember coming across one of the foodstuffs called cassava, and whereby actually they were looking at the thiocyanate part of the cassava for management of sickle cell crisis. And I thought this was quite very exciting. Maybe we need to go deeper into unlocking some of these micronutrients that we think could benefit our people. One, it would be cheaper, it would be probably acceptable, and also safe. Thank you, Chairman.
Thanks very much, Okwi. Just to update you, I think you're missing the information that we lost Kof close to a year now. We pray and we hope that he is resting in peace. But obviously his legacy endures. So, but your point again is well taken, and we hope there will be proper clinical trials. I insist on this, proper clinical trials to test the macronutrients and other supplements so that we have very, very strong, very scientific recommendation to our patients. So we shouldn't rush on that one. I should thank everyone for attending. We've had very good attendance. At peak, it was, I think, 44 participants or so. Thanks for staying late. The link was posted for post-webinar feedback. Hope you can access the link and provide your feedback on that. Otherwise, I would like to thank all the speakers for organizing, for preparing very good presentations and leading us through this important discussion. Thanks also to the organizers, SADC, Haida, Mario, and others for all the logistics, and everyone for participating. Thanks very much, and until next time, goodbye.
Thank you. Goodbye.
Bye.
Thank you.